So, with that, what I would like to do is invite up the panel. Our panel is made up of payers who are working with populations both in managed care Medicaid as well as the expansion population, and we're going to let them talk a little bit about the experience that they see. So if my panelists would mind joining us on the stage, if you will. Yeah, I think there are...
They're not two-sided.
No, sorry. You have to guess. You have to read backwards. Okay, so joining us on the panel, Lisabritt Solsky, who's the Executive Director of the WellSense Health Plan. Sam DiCapua, who I asked how to say his name and then I still messed it up. Dr. DiCapua is the Chief Medical Director for New Hampshire Healthy Families, Celticare Health, and CaseNet. And he's also remains as a family practitioner in Wells, Maine, so brings that perspective to us as well. Stephanie Richardson is the Director of Government Programs at Harvard Pilgrim Healthcare, and Tom Policelli is CEO of Minuteman Health. So I'm going to ask each of the panelists, excuse me, to take a few minutes and give us a little bit of perspective on the unique characteristics of the population that they're serving in their health plans. Really thinking about, what is unique for these folks that they serve as healthcare consumers. And reflecting on that, what sorts of services does that mean need to be available for this population that meet those unique characteristics? And we'll start with that, and then we'll open the floor to questions, and then I have more questions if you all don't. So, Lisabritt, could you start?
Sure, happy to. Good morning. Thank you for having us. So I'm going to pick up a thread that Deb introduced earlier this morning about the social determinants of health and how when we as a Medicaid payer are trying to engage our members in appropriate use of care, that's frequently not their biggest priority. The incidence of homelessness and food insecurity and substance abuse are really overwhelming, both to the individual member and at times to us at the plan. So I think about the type and the quantity of services that we offer to try to address some of those social determinants of health to the greatest extent that we can, with both the limitation of funding, but also the inherent limitations, so the things that Deb said can be paid for and can't be paid for, in order to alleviate some of that distress. Some of the most important things that we do, and Sam will say many of the same things. So with the next question, make Sam go first. Because frequently when we do this, we say what he said before. But we send a lot of our care managers, and we have some represented here in the audience today, but we send care managers into the community to find our members when they've fallen off the grid. So these are members that we were maybe actively following because of maybe having just been discharged from the hospital, or maybe there's somebody who was flagged as complex or has volunteered to participate in care management for one reason or another, and then we can't reach them anymore. So we send care managers into the community to try to figure out what has happened with this individual or with this family so that we can re-engage them with care. I think the other most significant thing that managed care certainly is not solely responsible for bringing to the Medicaid space, but I think has virtually blown the lid off, is transportation. So there was always a transportation benefit under Medicaid, yet the conventional wisdom is that there hadn't been one until there was managed care. And that, is indicative of the fact that it was like the best kept secret. And when managed care came to town, we really saw the value, because that's a tremendous barrier, particularly in this state. Its rural nature in being able to connect people to care, particularly if it's sort of not a scheduled appointment that's been on the calendar for 3 or 4 months, but something that comes up more emergently because you have a child with that sore ear that needs to be seen today. So the transportation spend since managed care came to town has literally blown up, as Deb can attest. But I feel like that's a good news part of the story, because that correlates to appropriate use of care that wasn't happening before. And annually, I attend one luncheon for the network of drivers that participate through our vendor. And it's a luncheon just to value their service over the course of the year. And to sit at the Grapponi Center in a large conference room and meet with the folks who are responsible for transporting our members every day and see the economic impact that has had across the state is really overwhelming. Again, I feel like it's a good news story. It's been an economic driver. Many of those who are employed by our vendor are now using exclusively a Medicaid portfolio to support their business. Some of them are new Americans, they are refugees. So I think, that's a good news story about the greater impact that transportation has had across the system in addition to just serving our members. And I'm going to let Sam jump in because I know there's a lot of similarities. I don't want to steal your thunder.
I would say another issue is the degree to which there's a comorbid connection between behavioral health and physical health conditions. And I think when you start to look at it, and we've looked at this, so we've introduced an integrated care model where we're integrating behavioral health and physical health together into one team, and we're looking at individuals from sort of a holistic perspective. If their primary problem is behavioral health, they're assigned a behavioral health specialist, and if their primary problem is physical health, they're assigned a nurse case manager. And the degree to which they interact and how that affects the outcome and affects the way they get care is pretty profound in this population. And I think the data does bear that out, as Joe showed. I think the other thing is engagement. This is a population that is very difficult to engage, like Lisabritt was saying, for a variety of reasons. Not the least is the social determinants. It's hard to engage with your case manager if you don't have a place to live, or if you're living in a car, or you're couch surfing at friends' homes, or if you're in an abusive relationship, or if you don't have food. And so really our case managers are, I admire them profoundly because they use their motivational interviewing skills to really try to find what makes the person want to engage with us, because we can't help people we can't engage. So engagement is a very big factor with this population. I would echo a lot of what Lisabritt said around sort of transportation and specific services. The other thing that I would be totally amazed by, or was totally amazed by, is the level of disease burden that some of our children in this state have. I've been in practice over 25 years, and I've been in the textbooks more now since I've been doing this job than I have my whole 25 years of practice. The disease burden is profound, and these children and families are affected in ways that go so far beyond just the healthcare issues that they're facing. And again, I'm always amazed at how well they advocate for themselves. We have a lot of members that advocate really well for themselves. You would agree?
Yes, absolutely.
And we hear from them, and we try to work collaboratively to make sure they get the right care at the right time in the right setting. That's sort of my mantra at the health plan: right care, right time, right setting. And I think those are the two things that come to mind: engagement and the sort of interplay between behavioral health and physical health as major issues.
Well, I think the good news is the carriers, we're all trying to treat this population as holistically as we can, and we're seeing the same trends in trying to really manage this population. I think, as most folks probably know, we are not an MCO, and this is a new space for us, beginning with the Medicaid expansion population. In that short time of 1.5 years, we really have learned a lot about this population, but there's always even more to learn. So we are really trying to arm ourselves with as much knowledge as we can. We see the same things with this population. They're very hard to reach. The addresses and the phone numbers that we have, if we have them, may be outdated. They may not have updated the state. They may not have called us. So it's really hard. We definitely do put those caregivers in the community as well. So we have nurse case managers, we have pharmacists out in the community. We see that this population, while small for us, roughly 11,000 members of our over 1 million membership, they are definitely more prone to have behavioral health issues as well as other medical issues. We really are trying to integrate those services with our joint venture with Benevera. And as folks know or may not know, That's a partnership that we have with the provider systems here in New Hampshire with Frisbee, Dartmouth Hitchcock, Elliott Health System, and St. Joseph's. And that's provided us a robust data set to really take a look at this population, not only from the health plan perspective, but also from the provider perspective. In terms of what we've been doing around behavioral health, we are looking at, we have grand rounds that include behavioral health and medical staff, so we can really look at the member, as we said, in a holistic manner. And that also helps us determine who we need to reach out to. So of course we've got the data, that we've got analytics that helps drive who we need to reach out to, but then also those grand rounds also really help us understand how we can really effectively care for this population.
Great. Thanks. Tom?
First, I'd just like to thank you for what great data. I mean, this is just, I'm a total geek and I was trolling. This is great. I'm going to be all over your website and my kids are going to hear about it at dinner. And I feel bad. For those of you who are interested, there's more data downstairs. We brought our own stuff. It's not in your packet, so a little plug, there's more stuff. Like Stephanie, we are not a Medicaid plan, but through the Premium Assistance Program, we now have 3,500 members who are a part of our, our overall membership base. Completely different. And you look at our statistics, and our stats look a lot like what you saw on the slides up here. The PAP population is very similar to a Medicaid population. And so that means, and you'll see in the little thing here, it means, for example, ER utilization for in-network people, it's 3 times what we have for the rest of our population. For people who go out of network, it's 6 times. Behavioral health, in-network, 5 times what the rest of our population is utilizing. For out of network, 10 times. I mean, just completely different population. And for only 3,500 people. So what that means is, well, I mean, just to be blunt, I'm afraid. I'm afraid because this isn't who we are. That's who I am, I should say. I haven't been a commercial healthcare guy my entire life. We've got some great people who this is their space, who've joined us, but you look around the industry and there's commercial carriers and Medicaid carriers and Medicare carriers, and I think there's a reason for that. These are very different businesses with very different populations they're trying to serve, and so we are trying to, for under 10% of our population, pivot our entire company to try to make sure they're getting what they need, and the practical answer is they're not. I don't know if they are in any circumstance, but we're doing everything we can. Same thing, trying to chase people, find where they go, and this is the most terrifying thing I've ever been a part of. I thought commercial health insurance was hard. This is really hard, especially when that's not what we do,
So
what we thought we were doing.
If I could pick up that
Sure.
point, because I find that when we meet with members around the state, when we meet with social service agencies and we talk about all of the things that we bring to the table to support our members, constantly, even people who are in this space daily say, I didn't know an insurance company would do that.
Right.
And that really is the dichotomy that you're describing. We as an exclusively Medicaid plan are built to serve this population, and so our infrastructure is informed by the needs of that membership, but it isn't consistent with what most people would consider what an insurance company will do.
Right.
But we have to by definition. So
Right. Right, and we're trying to learn everything that you know how to do. We're scrambling to try to replicate and do. And so if that's not enough, I have one other fear. And my fear is that right now, I'm going to get slightly geeky on all of you, although after what Joe just did, I'm not going to be too apologetic with being.
stiff competition.
So the PAP population is in with the commercial population right now, and there's one overall premium, and so you're now one price for 2 incredibly different populations. And my concern is that as people start seeing the financial impact of that the support for the PAP program is going to go down, and then these people could be in trouble. So just to give you some round numbers on it, these are round because there's competitors and none of our rates are done yet, but in round numbers, if we look at 2018 as having the individual market, in the individual market now about half of that is PAP and about half is not. The individual market has an increase of say 35% for next year. At least I'm talking, extrapolating Minuteman data here, so everyone has their own. Actual medical trend is very, very low. So for the purposes of this example, I'll call it 0. Okay. The impact of the PAP population, it's under 10% of my population. On a per member per month basis, it's more than double what my regular membership costs. But since it's only under 10% of my population, it means that the increase, the 35% increase or so, about 10 points of that would be because of the cost, the actual cost of claims of that population. The last 25% is because of this other goofy program I can bore you with if you'd like, this federal thing called risk adjustment that is overscoring. And because of that overscoring and the uncertainty that that puts into the marketplace, we end up having to see a much, much larger increase. So and there's examples in our little deck if you want to check it out, but to me that's a really, if we end up with the market showing, and maybe 35 is not the right number, maybe it's 40 or 20 or 5 or whatever it turns out to be, a lot more. New Hampshire's been very successful in the individual market, far more than the rest of the country for the last few years, and my concern is that this could upset the apple cart. Not to be a total negative Nelly, we also have some ideas for solutions that we threw in here, and one of the things I just want to emphasize, one of the folks somewhere up here earlier today said, New Hampshire has done a remarkable job in pulling people together. I mean, look at this. The data is fantastic, and there is a kind of a joint problem solving mentality here that just we don't see in Washington, for example, very often, and it's great. So I'm optimistic we'll get there, but we have a lot of work to do.
Thanks. So earlier, a while earlier, you all had an index card, and hopefully you put a question or so on it. So I'm hoping that there are questions in the audience, and I would also hope that you all had a chance to ask them as we went along. But I want to open the floor to the audience to ask our panelists about their experiences, questions that you may have had on your card that we can answer now. Yeah, Kelly.
So I would like to ask Tom a question about the numbers that he just shared. Would I reinterpret what you just said about those numbers to be that the PAP population is just a loss leader for you, or that the margin isn't as generous for that population as it is on your commercial book of business?
It's a negative margin by far. And it's not a loss leader. You know, when a company puts out a loss leading product, it's because they want to entice you into the store, right? They price milk low because they know you need milk. You'll come in and then you'll buy whatever for a lot more with all the profit margins. So this is a program that people are auto enrolled. We didn't design ourselves to go after this population, and so we're not trying to entice anyone in or out. They just simply have before them the ability to buy the same product that the commercial market does. So I'm not sure. It's not a loss leader because that would mean that we're trying to get more. We're not trying to get more. We're losing money every member we have. But we're definitely losing money on it, no question.
Yeah.
I'm Debbie Kreiner from Granite State Independent Living. And so thank you for the data and you all talking more about it. And it makes me excited to think about we can use this data for kind of a predictive analysis. And are any of you using that? Because I know some states have to decrease from suicide to homicide. Really impactful. Is any of that data being used in more of a predictive analysis for intervention?
Yeah, I'll actually let the panelists talk about that, because I think from our perspective, from the research side, probably less so, but I know that there's a whole lot of work that the plans will use internally to try to use some of that data for their own planning, so I'd love to hear from the panel on that.
So exactly, we don't necessarily take the statewide data. We look at our member data, and we populate a registry based on past claims that have been submitted. So to make a rather benign example, if we have a claim that somebody has had a positive pregnancy test, we put them in our registry for our pregnant women's program to try to do some outreach about how to have a healthy pregnancy and give them more supports if it turns out that they have a complicated pregnancy. So we use our claims data predictively in that way. It gets increasingly complex as necessary because we have multiple care management offerings that we can share with our members, but we don't necessarily look at the statewide data, partly because it's a little stale and wouldn't tell us down to the member level exactly what we need.
And I would say the same thing. We have fairly robust predictive modeling capabilities based on our claims data and actually our forward-looking utilization data. So think about claims as looking in your rearview mirror. Think about utilization data in your care management system as looking out your front windshield. So we have fairly robust capabilities from a predictive modeling, and it's part of our algorithm for our care management outreach. So members that hit a certain predictive modeling score, which takes into effect claims and utilization, are we're predicting that they potentially will have events in the future. We'll proactively reach out to them based on that predictive modeling score.
And I would just throw in too that sometimes it's the absence of a claim that triggers the need for care management. So our partners in behavioral health, Beacon Health Options, they look at children who have claims for psychotropics, but no corresponding therapeutic claims. And so they are targeted for outreach so that the family knows that, you know, therapy is a complementary offering to help manage their child's behavioral health condition. So it's not just the presence of a claim, sometimes it can be the absence of a claim that makes somebody appropriate for outreach.
And that's a good point. I think unless you guys have something to say, but
I'll add when you're.
okay, but if I can comment on the question about the costs of care, and as we sort of explore our integrated case management model, it's the absence of care that really makes us nervous. And I think, you know, we're looking for care to shift from sort of more cost, high cost, ineffective sort of environments like the emergency room to more lower cost, more effective care coordination environments like primary care. But what we see a lot of times with the integrated care model in the members that are most highly affected is no care. And so it's really engaging them where they should be engaged, whether that's at their primary care provider. So we have the full expectation that doing the right thing is going to potentially increase our costs, but that increase in cost is going to bear fruit for that member especially, and then later down the line in the overall cost of care for that member over time.
And I would add to that, so we are using our internal data to determine whether some of our members are eligible for care management or they're well suited for care management programs. We're also using that data to see what other programs we should be developing for this particular population. So just to put out a few statistics that we are looking at, the good news is that these members are using their services, which is great news. In comparison to our fully insured book of business, they're seeing PCPs 78% of the time, as opposed to 74%. So right in line with our commercial market, but actually a little bit better. However, their ER utilization is still very high. So we're looking at that. It's 5 times higher than our commercial fully insured book of business. A lot of that has to do with where are they in their community. Is it easier to get to the hospital? Is there transportation to a hospital as opposed to maybe some of the rural areas? So that's something that we're looking at as well. We have high utilizers of substance abuse treatment methodologies such as Suboxone and methadone for the opioid treatments. And this is very high for us. It's 13% higher in terms of membership than our commercial book of business. So these are things we're looking at to see what type of programs we can develop to help treat the holistic person. And we talked about social determinants too, looking at that. So as we have folks engaged in the community, we're really trying to look at what is going to be the best outcome for this member? How do we really treat that member in their environment as opposed to trying to put those members in, you know, a traditional setting?
Great, thanks. Tom, did you want to talk about any of the analytic work?
Yeah, the only thing for us is, as Deb was talking about earlier, when you have a small number, we only got 3,500 members. So trying to find, you know, how much is happening per thousand when you only have 3,500. A lot of categories you just simply don't have meaningful enough data. So that's the hard part.
Great. Yeah, Vic.
Well, I'm Vic Topol from the Center for Life Management in Erie, and I have a question that probably wouldn't expect me to ask. That's why I want to ask it, and it has to do with perhaps at times the lack of integration that might exist within your own corporate structure when you have a physical health plan and you have a behavioral health side of the plan. Could you talk a little bit with us about how you're structured so that it's less, less, should be more integrated, but it's actually less integrated?
So I guess I could give you a
We're not
vignette.
integrated, I guess, excuse me, we're not integrated, but there's been scenarios that have been painted whereby the health plans and the behavioral health side are not necessarily in sync with each other.
Yep.
You know what I'm referring to.
I think so. I don't know, you'll correct me if I'm getting it wrong, but I think internally, our structure is that we have our behavioral health care managers and our, physical health care managers who sit side by side and can easily, stand up and ask their colleague a question or collaborate about a member. I think others have mentioned rounding that we do on a regular basis about members who are really in a predicament, and we want to look at the whole person, so we involve our behavioral health care managers as well as our physical health care managers. But one of the sort of aha things for us, just in the few years that we've been present, is that in as much as we are co-located, that is not synonymous with integrated. And so, we are working hard to sort of take that to the next level. Sitting next to each other is excellent, but that is not a panacea either. So a lot of it is sharing techniques, sharing, insights across the discipline. So, we might have a care manager who specializes, say, in the CFI population, but knows that a lot of the members they work with can become depressed because they're isolated. And so they might talk to their colleague on the other side of the cubicle to say, what other tools do you have that I can use to try to engage this member and be more proactive in all of their health care? But I agree, we're not 100% there. It was a bit of an aha that it's time to take it to the next level.
Yeah, I would agree with that completely. We started down the path of integration a little over a year ago, maybe a little bit more, and our teams are actually co-located. We talk about members in a sort of unified way. We don't distinguish between behavioral health or physical health unless the situation dictates that. But I do agree, so structurally having a vendored relationship with your behavioral health arm of your organization is not ideal. We need to be more nimble. We need to be able to react to situations in a much more quicker manner. And I think the trend is going to be moving away, in my opinion, from sort of that vendored relationship into a sort of a plan-controlled behavioral health model, for lack of a better nomenclature to give you. But I do agree. I think, integration needs to mean true integration. It needs to mean integration not only across clinical lines, but claims and everything else that goes with that.
Yeah, and I would just add, we're definitely committed to treating each member holistically and trying to provide an integrated experience for them with behavioral health and medical. And yes, we do have a carve out in our behavioral health setting as well. I did speak about some of the rounds that we're doing through our joint venture of Banavera. We also, through that partnership, have the warm transfer from the medical provider to the behavioral health. We're also looking to have behavioral health providers in that same office, and that speaks about the provider, but we're also, looking at things from the health plan perspective as well. That joint venture is not just about Harvard Pilgrim continuing on a path as a health insurer and the hospitals continuing on the path as hospitals. It's a partnership to improve the system and improve the quality of life for our members.
Tom, you want to add anything?
Yeah, we're a small company. We have 62 employees. We have, and we're integrated. We're also co-located. We're also, sitting on each other's, almost on each other's laps. But we don't have, we currently don't have an outsourced relationship. but it's something we keep looking to evaluate. So we evaluated it last year, and we elected no at that time. When this is another look this year, it's one of the big questions before us. So we need to keep looking and looking at different vendors, looking at what they can do, and going through what, again, with only 3,500 members, what limited data we do have to see what we think we can would be the best answer for them.
Gail, did I see?
I'm Gail Brown, I'm with the New Hampshire Oral Health Coalition. And your comment about care that is not provided or has not been available, unmet care, brings me to one of my areas of interest, which is dental care and oral health care. And so my question, and then I want to make a comment. My question is, have you as providers, and I know some of you have talked with you about it, taking a look at oral health care and dental care that's not occurring in the community in your population? One of the things we say in our office is if you're not managing dental disease, you cannot be managing health care nor healthcare costs. And so we know that diabetes, cardiac, substance abuse, pregnancy have some relationship at varying degrees to oral health and dental health. So I come back to my question, are you seeing that? Are you starting to measure it? Do you have thoughts for us? All of you, actually, or any of you.
So, I will start. The one important caveat, and I don't disagree with anything that you've said, as you know, and we talk about this, but we have to remember Deb's introductory comment that pound for pound, this is a children's program. And fortunately, the Medicaid program is required to provide dental services to children up to the age of 21. And currently that is provided by the state fee-for-service system. It's not part of the managed care system. But we also know that, however, we still have that group of adults that don't have access to any kind of preventive oral health care. And I had the benefit in my years at DHHS of studying at the altar of Dr. Peg Snow, who really, insisted on the importance of oral health. The head is connected to the body. We've been saying that as it relates to behavioral health. It's equally true as it relates to oral health. So we talk about this a lot, and unfortunately, I don't know that we, WellSense, as one MCO, have all of the tools to be able to bring a solution to bear for all of these adults. It really has to be a coalition, and I know that's your business, but I think that that is an area that this state could do well to improve in, and we get ad hoc data requests from DHHS all the time on a variety of different topics, but I think that this is something that would be meritorious of more exploration to see if we can make any kind of causation or correlation type connections around incidence of some of these conditions with what we see on the medical side, and correlate that in any way to the absence of good oral health care.
Anybody want to add anything to that? Or?
I would agree. Just, I think the data would have to be a shared sort of data approach with the state.
Well, I would just say, while Medicaid traditionally is a child's program, the expansion program is an adult program with the single adult population. So we do not offer dental within that particular benefit, but under the ACA, pediatric dental is a covered benefit under the essential health benefits, which is available under our commercial plans.
Okay. Steve.
Hi, Steve Onnet from the Hospital Association. Thanks very much, very interesting. We've talked, and we've heard a lot about this over the last several months relative to the increase in ED utilization. Can you talk a little bit about what you're seeing in terms of who those patients are there anything that you're seeing that's driving some of that, and what are some of the successes that you've had helping to sort of reorient people to lower cost primary care, other settings?
So I can start. In terms of the ED use, we're seeing, one, we have volume because we have this new expanded population, so we have more members, and they are visiting more often. Oftentimes, these folks may not have a PCP, or they haven't seen their PCP, and it may just be the most convenient option to them. So we really do need to work very hard to educate this population on the role of a PCP, and we are trying to do that as much as we can with Benevera. I feel like I keep plugging Benevera. But we're doing that outreach to this particular population. So for our new enrollees, we have a target to reach out to them. And if we try with their address and phone number, if we can't do that, we're really trying to see what other data may be available to get in touch with these members. And we've had this discussion with Deb about the data, and I've had this discussion with our partners at Benevera about the data we get from the state, and it's only as good as the members provide. And one of those driving factors is one of the social determinants. Do they actually have a true residence? Or are they giving information that might be valid for a day, a month, or a week, but when we go to do the outreach, we can't reach them because they've moved on to that next location. So I think those are some of the hurdles, and I think those are the folks that are visiting the ED more often if they have other social determinants going on with them. And also behavioral health linked in with that can also increase the visits to the ED as opposed to getting care in separate settings, going to the PCP versus a specialist versus a behavioral health provider.
Sam, yeah?
Yeah, I would just say that for a large part, I think our providers are doing a really good job at managing the ED utilization. If I look at my utilization in our plan relative to our corporate partners' plans in other 19 states, we're among one of the best as far as utilization goes. I would say that the utilization does get more complicated as the member's disease burden or comorbid factors increases. I'll give you one example. We had a young member who lived with his father who had some developmental disabilities. Father was very ill. The father was in the emergency department quite often, and the son would go with him. And over time, the emergency department became that person's support system. He was known there. They would high-five him. He would have lunch there. They would know what his favorite things were. And unfortunately, his father did pass away. And that pattern of ED utilization continued with this younger person until we were able to sort of figure out what was going on and then get the appropriate social services in place and replace that sort of family that he established there with a different sort of family that was more sustainable and more appropriate. That's a good example. I also think the providers are in need of data. A lot of times, like, attribution issues are a big issue. So providers can't manage what they can't see, right? So you don't know if somebody's attributed to your panel. You can't necessarily manage their utilization because you're not looking for it. So I go out quite frequently and meet with providers, and we bring actionable data regarding ED utilization to them. We talk frequently about attribution and, how do we sync up our attribution so that the people that we have attributed to you are actually the people you're seeing. And again, there's a lot of work that's done with individual members. So I think our provider community is largely doing a good job. Data is always important, and that's one thing that we are very sort of robust with and we can provide. And I think as part of our alternative payment methodology, ED is always certainly in that equation.
Anything to add?
I would just say, in as much as we talk about emergency department utilization, there is a big difference between appropriate use of the emergency department and inappropriate use of the emergency department. And so to the extent that we as payers are looking to reduce utilization, it's on the inappropriate side. It's going to the ED for ambulatory sensitive conditions that would be better treated in a primary care setting. We never want to dissuade our members from using the emergency department when it's the most appropriate place for them to go.
Great. We probably have time for one more question. Tyler, did you want to?
Tyler Brandon from the insurance department. Are there, among the benefits, the services, the programs that you offer, is there anything that comes to mind that perhaps should be financed through another mechanism? I'm thinking, school systems, other government programs, and essentially you're being asked or expected to operate beyond your scope, beyond your sort of business core model.
I actually feel like further bifurcation of the funding creates more trouble. And I think in the service of our members, we go beyond a traditional insurance company's scope in the effort to help that person to become stronger and more stable up to and including home visits for kids that we know are in, the DCYF system, because we know we can get there faster. So I'm not sure that I would follow that premise to its conclusion.
I would actually go one step further. I would prefer to pay them to manage the population because they're built to do it. So put a tax on all commercial insurance, I'll pay it, but because I'm trying to, on a very small scale, replicate what's already there, which doesn't strike me as terribly efficient. And we're putting more complexity, which equals more cost and lower, less good outcomes into a system when we don't need to do it.
I think we actually probably have time for one more question. Yeah, that's right.
I'm Dick Ames. I'm a state representative from a relatively rural area in Jaffrey. And I hear a lot, so I'm interested in sort of the policy dimensions. I hear a lot of complaints about burnout in mental health service programs, treatment centers, and about difficulty in recruiting those direct care people, those people who go out that you've spoken of, and keeping them that relate to perhaps pay and the ability to provide adequate support to them. So sort of the broad question is workforce on these basic direct care at this level of service that is so important that we seem to be struggling with.
So you raise an incredible and important point that hasn't been touched on yet this morning. We do find that in trying to coordinate care for our members, that the agencies that we contract with simply don't have the workforce available at the time that that member needs the service. And so there is oftentimes a delay between when the need is identified and when care can be rendered, particularly if we're talking about in-home services. This is the kind of care that has low reimbursement, but yet I think all of us would agree is an incredible investment because it keeps people out of the hospital, it keeps people out of a more expensive setting, but there simply isn't the workforce there. For a lot of home health care providers, I know Gina's over there, they're injured frequently on the job. So it is a very complex issue, and we have one of the lowest unemployment rates in the nation right now. It's a burden and a curse sometimes to have very low unemployment because these jobs are not the first ones that people are looking for.
I would say it speaks towards sort of the excitement of the integrated delivery networks. So is it the right thing to have care delivered separately outside of sort of a primary care model? There's a lot of organizations, South Central Foundation of Alaska, that actually brought all of their behavioral health care right into the primary care office, including psychiatric services. Now they're paid a blended rate because they're able to do that because of the funding from the federal government. But I think the integrated delivery networks potentially, or thinking about providing care in a different model that's not actually quite so transactional, could potentially be the solution to that. But I think, innovation, I think, is going to solve potentially that issue. And I'm really excited about the idea and possibilities when you start to look at holistic approaches to populations and get it out of the silos.
And I would just add one way to potentially look at this is statewide, all stakeholders. Back in 2009, I served on late Mayor Tom Menino's task force on primary care. There's a significant shortage in Massachusetts, and it was something that the mayor really felt very strongly about. So he pulled folks together from the health community to come up with several recommendations. And I think maybe that's something the state may be interested in looking at. How do we bring those particular providers into this community? How do we make New Hampshire attractive? Is it, a pipeline through medical school? Is it loan forgiveness? These are some of the things, it's been a while since 2009, but we came up with some comprehensive recommendations to look at primary care, which could probably be leveraged in this situation.
Tom, did you want to? All right, I think I've been told we have time for one more question. Yeah.
Tom Sherman, I'm a gastroenterologist at Exeter and know many of you from having been in the legislature. Having been a part of the organization and development of the New Hampshire Health Protection Program, Mr. Policelli, did I get your name right, brought up to me what is an absolute bombshell comment, which is the cost of the commercial carriers doing something that specialist carriers are trained to do and do better. So you're talking about the cost on premiums across the exchange going up potentially as much as 35%, being driven, at least in part, by this small component of the population representing 10%. I'm wondering if there is data, either linear data based on the MCO experience when they were taking care of the expansion population, and then going into the commercial carrier, looking at the cost to the state, the cost to the federal government, and most importantly, the outcomes for patients. Whether that data existed. When we originally were working on this, we were hoping we would have enough data and enough time with the MCOs in place to understand which of the two models would be the most cost-effective and best for the patients. And what you're saying, essentially, is that not only is it driving up premium costs, but you would prefer to be having the MCOs managing that population and not having that responsibility, if I'm interpreting it correctly. Is there the data on cost to the state and outcomes based on the model that was used for the expansion population?
Well, actually, I'm going to shift that question to Deb, because I think she's probably...
So what we do have is initial data on the experience of the Bridge program, which is the name of the folks who were on the bridge to the marketplace. So they were expansion adults covered by the MCOs in the first 17 months, Lisabritt, 18 months of the program.
Yeah.
And right, roughly, right. And the experience they actually presented as less risky than we had priced them at when we priced them for the MCOs. So we are currently looking at the underlying experience of the first full year of the PAP program to see if something has radically changed from the folks that we first served, or exactly what else is going on, if there was some richness of the Medicaid benefit that really supported the folks in the program, and that they don't have that same access to those same sort of supportive rich benefit on the qualified health plan side. So with a fair amount of tact, what I want to say is I don't think it's a fact yet that the premium assistance program experience is as divergent as it may be, but we are working on it. Because of course we want to know also, and we must know, and as you know, since you were there when it all began, we have this tricky little cost effectiveness test that we have to ensure so that the program, so the coverage can.
Yeah, I'd say there's three components of the cost differential, right? So first of all, you've got the PAP population is more expensive than the commercial population, you know, from a starting point. They use more services, it's more expensive to start. Then the second question, and so by blending, taking in the individual market, taking half the old market and half the new market, you end up with a price that, you know, you would think you'd be kind of in the middle. So that's the first part, is they just cost more. The second part is, are commercial carriers built to manage to the same cost that you started with, or are we now trying to replicate what the MCOs were already doing? And I tell you, I'm replicating, right? So I'm assuming that they're better at doing that than I am, and that it costs me more than it costs them because I'm building, right? So, and we'll see. But so that's kind of the second component. The third, which is I have to stand up. The third component has nothing to do with anything that was designed by anyone regarding this, and that's that federal risk adjustment. And basically, it makes the whole individual market much more volatile. So when you just had that initial commercial population, it's made it very volatile, which is making premiums jump up. When you then introduced a second population that started at a different level, now you've just taken your volatility and it's just exploded. And so that's why I said when you break down what a big increase is, it's that last layer. It's the question mark that the volatility of this federal program puts on that makes you just say, geez, I gotta make sure we cover all downside, so.
So just a
Sorry, sir.
concluding remark to plug, there is a legislative commission that is looking at all of those questions.
That's right.
It's chaired by Senator Bradley. We haven't met in a while, but I'm looking forward to those meetings resuming because these are really important questions that I think policymakers need to grapple with to figure out what the next phases of the health protection program will be.
Right.
So, I promised you we would be ahead of schedule one time today, and we were. I hope you enjoyed it. It's not gonna happen again. So, I think we're gonna need to shut this panel down because we need to move on to our next session. Couple of quick things. First of all, most importantly, please join me in thanking the panelists for their recent sessions.
We're missing a lot. We'll do it tomorrow.